Hello everyone, I'm Dr. Saurabh Sharma. So again in another demo of Resident Masterclass. Today I'll take an important clinical topic starting from the first year to the final year, a Ptosis examination. We should know in any topic we should start from the scratch and go to the very advanced level as well for final years also. Just to tell you, of course, I have told you this disclaimer, this is a teaching lecture for residents, not a webinar or a presentation. The main purpose of this is to understand the basic concepts of the topic, prepare for Viva and help in theory examination, and very important, how to do important clinical techniques, clinical examination. That will be very helpful for third year who are going for exams, clinical examination skills and how to write in a theory exam. So let us start from the scratch. Ptosis is drooping of the upper eyelid. So which are the muscles which elevate the upper eyelid? Two muscles. One is levator palpebrae superioris and Muller muscle. So we should know detail about them before going into the topic of ptosis. And this anatomy of the eyelid is important. If we go anatomy of the upper eyelid and go from the anterior to posterior, what we find is the first layer of the eyelid is the skin, then subcutaneous tissue. Then we have the striated muscle. Okay, the striated muscle, they have two striated muscles. One is the LPS, which we'll talk about, which elevates the eyelid, and the second one is the orbicularis oculi, which closes the eyelid. Then under the striated muscle there is nerves and arteries present, which is the areolar tissue layer. Then we have the fibrous skeleton, which provides the strength to the eyelid. This green thing is the tarsus, tarsal plate, and the continuation of the tarsus is known as orbital septum. So tarsus and orbital septum give strength to the eyelid. You can see in this here also, this is the tarsus, and here the continuation orbital septum. Then we have the smooth muscle known as the Muller muscle, and the last layer of the eyelid is palpebral conjunctiva. So we should talk about the muscle, which is LPS, very important. The anatomy of the LPS, origin, insertion, nervous supply and the action. So this is the orbit, this is the anterior part of the orbit. This part is the apex of the orbit, posterior part, apex of the orbit. Where what is this? Is a fissure, superior orbital fissure, and there is a fibrous condensation sheath over here known as annulus of Zinn. The importance over here is the rectus muscle, superior, medial, lateral and inferior rectus are originating from the Zinn. Above this is superior oblique, and above this is the origin of LPS. From which bone? That is important. From the lesser wing of sphenoid. And where it is present, in which part of the wall of the orbit? Roof of the orbit. Greater wing in the lateral wall, lesser wing in the roof, and body in the medial wall. So from the roof of the orbit, LPS is originating. Then it travels. See, it is traveling. This is the LPS muscle I am marking. It travels horizontally, and there is a ligament known as Whitnall's ligament, which dips it vertically. And after vertical dipping, it has two fibers. One is a superficial fiber and one is a deep fiber. The deep fiber is inserted over here. What is this? Tarsus. Inserted into anterior tarsus. And the superficial fibers, see, LPS is present only in the upper eyelid, not in the lower eyelid. Superficial fibers get inserted into the skin of the upper eyelid. And you have seen yourself in mirror. अपने आप को देखते हो और किसको देखते हो? तो अपने आप को देखते हो शीशे में तो देखते हो ये horizontal lines. What are these lines? These lines are eyelid crease, which is formed by the superficial fibers of LPS inserted into the skin. Some have multiple, some have one line. Depends how many insertions are there. So superficial and deep insertion is like this. And this ligament which I am talking about, the Whitnall's ligament, which separates the horizontal into the vertical LPS, which you can see over here. This is the Whitnall's ligament. Now this LPS muscle, while coming into the tarsus, has some aponeurosis. It goes into the, see, this is the right orbit. It goes into the medial palpebral and the lateral palpebral. It joins the medial and lateral palpebral ligament, forms the aponeurosis. So LPS muscle forming the aponeurosis, and that is the extension of the LPS. So it fans out into the lateral and medial parts as well. and it is present only in the upper eyelid. So that's the origin and insertion. Nervous supply, very important. Third nerve supply the LPS. And what is the action? It present only in the upper eyelid. So it elevates upper eyelid. How much it elevates? Normally it elevates more than 15 millimeters. More than 15 millimeters it elevates the upper eyelid. That's the origin, insertion, nervous supply and the action of LPS. The second muscle, which is a smooth muscle. Okay, let's see this diagram, a complex diagram, but let us see. This is the orbit, a lateral view. This is the LPS muscle, which is inserting into the anterior part of the septum or tarsus, and some superficial fibers going into the skin. What is important here is, look at this muscle. This is the smooth muscle known as the Muller muscle, also known as superior tarsal muscle, originating from the lower end of LPS and inserting again into the tarsus. Alright, it also elevates the eyelid. It elevates 2 millimeter of the eyelid. Alright, so these are the two muscles which are important. Okay, next let us come to ptosis. Drooping the upper eyelid is known as ptosis. If we divide the ptosis, classify the ptosis, a mechanistic classification of ptosis, it can be congenital ptosis and acquired ptosis. Congenital ptosis and acquired ptosis. Congenital ptosis, if we talk about, you can see the patient standing face to face. This child is, this is the right eye, this is the left eye. What is the important feature of congenital ptosis? There is absence of lid crease. Why? Because there is a LPS muscle dystrophy. There is a dystrophy of LPS. There is a dystrophy of LPS. Since birth, the LPS is not formed. If LPS is not formed, you can see lid crease is absent. This is known as congenital simple ptosis. When only LPS dystrophy is there, lid crease is absent, and there is a sign known as lid lag sign which is present. What is lid lag sign? So if you normal, this is our eyeball, this is the eyelid. Okay, if the eyeball looks down, the eyelid follows the eye globe normally. Why? Because while the eyeball goes down, the LPS relaxes and it follows the eye globe. Here what is happening? LPS is dystrophy. So it cannot contract, it cannot relax. So when the eyeball goes down, LPS does not relax, it remains behind, lags behind. Important feature of congenital simple ptosis. This is simple ptosis. Now it can be complicated ptosis as well. Complicated ptosis can be associated with, you remember these three? I will tell you in short notes later on. Blepharophimosis syndrome, a double elevator palsy, means superior rectus palsy plus ptosis is there. Superior rectus elevates the eyelid. There is a addition between superior rectus and LPS. So both elevators are having problems. So the SR palsy is there in double elevator palsy, and there is a phenomenon known as Marcus Gunn jaw winking phenomena. Okay, acquired ptosis. What can be the cause of acquired ptosis? LPS. What is the nervous supply of LPS? The third nerve. So either there can be a neurogenic cause. Neurogenic cause means the nerve is not functioning well. The third nerve is not functioning well means third nerve palsy. So third nerve palsy can have ptosis. Or which is the other muscle? Muller muscle. The nervous supply of Muller muscle is sympathetic. And if there is a loss of sympathetic supply, there is Horner syndrome. So third nerve palsy and Horner syndrome are examples of congenital, example of neurogenic ptosis. Alright. Either the nerve is having problem or the muscle is having problem. Myogenic cause. Examples. Okay. It can be myotonic dystrophy, progressive external ophthalmoplegia, in which the muscle is having problem, LPS muscle is having problem, or a neuromuscular junction like myasthenia gravis. So neurogenic cause, myogenic cause. or a mechanical cause. A eyelid tumor or a eyelid edema will mechanically push the eyelid down. If you can see over here, the left eye of the patient, there is some tumor. This is a plexiform neurofibroma. It's a tumor of the eyelid. It pushes the eyelid down, mechanical ptosis. And the last, aponeurotic ptosis. Aponeurotic ptosis seen in old age people. You must have seen in old age also the eyelid is slightly drooping. So see, the aponeurotic ptosis, because of the aponeurosis is not healthy. The LPS aponeurosis which I talked about, that is not healthy. So eyelid is not able to lift up, it droops down, seen in old age. This is the most common type of ptosis. What is the important point in aponeurotic ptosis as compared to the congenital ptosis? See here what is happening. The eyelid crease is absent because of LPS dystrophy. Here see, high eyelid crease is a feature of old age ptosis. High eyelid crease, old age ptosis, absence of eyelid crease, congenital ptosis, pathognomonic features. LPS function is good over here. The problem is not in the LPS muscle, it's the LPS aponeurosis. So LPS function is good in aponeurotic ptosis. It is the most common type of ptosis, also known as idiopathic ptosis. Alright, so this classification is known as a mechanistic classification of ptosis. Mechanistic classification of ptosis. If someone asks you in the Viva, you can tell. Next, how to clinically evaluate a patient of ptosis. Now this is very important. Comes in your exam as examination skills and in history writing as well and in theory exam as well. So starting from the classification of ptosis, how will you clinically evaluate? Of course, you ask the history. Always in history, you start with onset, duration, progress. Onset, duration, progress. It starts congenital or acquired, from how much time it is there and how it is progressing. It is unilateral or bilateral. Then negative history. It is associated with some other symptoms like decrease in vision. Why? Because if there is a congenital ptosis, if the eyelid is covering, there can be amblyopias. Associated with diplopia. If the patient has Herdner palsy, there can be squint, there can be diplopia. Or it is associated with variability. Variability, why? Because if there is a myasthenia, there is a variability in the ptosis. Or it can be associated with head postures, chin elevation. So when a congenital ptosis patient has bilateral ptosis, it tries to elevate his chin so that he can see. Then any past history of any surgery done. Surgery can affect the levator aponeurosis. Any drug history. Now which drug can cause? So this is topical steroids. It is seen not frequently. It is a rare cause. But topical steroids have a propensity in long term, they can cause ptosis. Not oral steroids, topical steroids. And always ask for familial history, particularly in patients of BPES, that is autosomal dominant. And if you have photographs, old photographs, you ask the patient to show him old photographs, which will help you how it is progressed till now. So these are all in history which you have to ask the patient and write down in the paper as well. Then comes the ocular examination. Starting with obviously visual acuity. Why do you take the visual acuity important here? Because the congenital ptosis patient can have amblyopias. So visual acuity is very important. Head posture. As I told you, why head posture? Because they can have chin elevation. They can elevate the chin to see. Eye position and ocular motility has to be done for ruling out third nerve palsies or ocular deviations, or if the patient has a double elevator palsy, as I told you, SR palsy. And pupil examination. In third nerve palsy, pupil is dilated. Horner's, pupil is small. So this important things, these two can be done during the initial part of the examination or after the measurements as well. And now simultaneously with this, you have to rule out whether the patient is actually having ptosis or not. You have to rule out pseudo-ptosis, false ptosis. For example, you see this patient. This is right eye, this is left eye. You see the right upper eyelid is covering 1/6 of the cornea, that is normal. But here you can see the right eyelid is looking like ptosis, but it is not ptosis. Why? Because the eyeball is small. So ipsilateral small eye means ipsilateral anophthalmia, microphthalmia, phthisis bulbi. It will appear at the patient have ptosis. So that you have to rule out by examining gross examination first. Ipsilateral hypotropia. Hypo means down, tropia means squint. If the eyeball is down, I told you eyelid will also come down. So it looks like a pseudotosis. Dermatochalasis, blepharochalasis, brotosis. If there is a ptosis of the brow, if brow is bulky and pushing the eyelid down, there will be a false ptosis. Similarly, blepharo and dermatochalasis are bulky eyelids. So they will cause a false ptosis. And this contralateral lid retraction. If the patient has other eye lid retraction, this eye will appear to have a lower level. So that is also have to be ruled out in a general examination of a ptosis patient. Alright, then comes the important things, measurements. Measurements of ptosis are very important. I'll show you how to measure also each and everything, but what all you have to measure, let us find out. First you have to measure see the distance between the upper eyelid and the lower eyelid in the center. Palpebral fissure height. Roughly it's about 8 to 11 millimeters. I'll tell you how to measure in a video. Now this palpebral fissure height has to be measured in a primary position and a down gaze position. Why in down gaze? Because I told you in congenital ptosis there can be lid lag. So in down gaze it is roughly about 5 to 6 millimeter. So you check whether it's having more than 5 to 6 millimeter or not. If it is more than 5 to 6 millimeter, there can be lagging of the upper eyelid. So in down gaze it has to be measured. The same palpebral fissure height in down gaze. Important, don't forget this. Then comes two important things. Marginal reflex distance 1 and 2. So here if you can see margin, upper eyelid margin to the reflex of the cornea. You put a torchlight, see the central reflex of the cornea and the distance between the upper eyelid margin to the center of the reflex known as MRD1. And if you take the distance from the reflex to the lower eyelid margin, that is known as MRD2. Normally the upper eyelid covers 1/6 of the cornea. So if for example if I take a cornea, just an example of 12 millimeters, lower eyelid is just at the level of limbus and upper eyelid covers 1/6 of the cornea, means 2 millimeters. So in this case normally how much will be the MRD1? The corneal reflex will be in the center of course. So 2 millimeters is already covered. So here in this case the MRD will turn out to be 4 millimeters and the MRD2 will turn out to be 6 millimeters. So these two important reflexes distance you have to measure and show to the examiner. I'll show you how to do it. Then similarly in the this is primary gaze. Okay, in the primary gaze you can see this is what a lid crease, but in the primary gaze it is known as a lid fold. So this is a marginal fold distance. This will give you an idea of the cosmetic during surgery, marginal fold distance. And if you do the same thing in a down gaze, see eyeball is going down now. In down gaze if you measure, this becomes a marginal crease distance. The most prominent crease till the upper eyelid margin, marginal crease distance. This will give you the incision, where you have to give incision during surgery of ptosis. Now from here you have to calculate the amount of ptosis. How much is the ptosis as compared to the other eye, or if it is the bilateral ptosis, how much it is ptosis as compared to the normal eye. So this can be found out from the simple palpebral fissure. So if the patient has a unilateral ptosis, from palpebral fissure PF of a normal person minus the palpebral fissure of a ptosis person, as in a unilateral ptosis, other eye is normal. So normal eye minus the palpebral fissure will give you the amount of ptosis. From MRD1 also, from MRD1 of a normal patient minus MRD1 of a ptosis patient will give you the amount of ptosis in a unilateral ptosis. In bilateral ptosis, you have to compare, you have to calculate from a normal. So I'll give you one example. For example, let us see this example only. Okay, this was a normal patient with corneal diameter 12 millimeters. Okay, and 2 millimeters should be the upper eyelid covering the cornea. So let us see this example. If there is a patient whose corneal diameter is 12 and the upper eyelid is covering 4 millimeters of the cornea, how much will be the ptosis of this patient? Now we know if the corneal diameter is 12, the corneal reflex in the center, the upper eyelid covers 2 millimeters of the cornea. 2 millimeters it should normally cover. Now it is extra covering how much? That is the ptosis. So 4 minus 2, 2 millimeters will be the amount of ptosis in this patient. So here in this bilateral ptosis you have to compare with the normal. See the corneal diameter, and 2 millimeters will be the 1/6, that is 2 millimeters, and 12 millimeters will be the upper eyelid covering normally. How much more it is covering? That is the amount of ptosis. And there is a classification of the amount of ptosis into mild, moderate, severe. Very simple. 2 millimeter ptosis, mild; 3 millimeter ptosis, moderate; 4 millimeter ptosis, severe ptosis. Now if one question, if I ask you, maths achhi hai, if a patient is having corneal diameter of 12 millimeters, his upper eyelid is covering 7 millimeters of the cornea, how much is the amount of ptosis? What is the grade of ptosis? So 12 millimeters is a corneal diameter, 7 millimeter the eyelid is covering. So amount of ptosis will be 7 minus 2, 5 millimeter will be the amount of ptosis, and the grade will be severe ptosis. Now you will ask us, sir, if the patient is having severe ptosis, for example 7 millimeters is covering the cornea, how will you calculate the MRD1 in this case? Because the eyelid will be lower level than the corneal reflex. Yes. So the MRD1 will be a negative in such a case. So for example, if a patient is having more covering of the cornea, it is covering at this level, this much covering the upper eyelid. The corneal reflex is somewhat about here. So what you do in the examination, you keep a scale in the margin of the eyelid and just elevate the eyelid manually till the point you see the reflex, and that will be the MRD1, and it will be a negative. It will covering the cornea, it is below the cornea level, it will be a negative MRD1. Important point. Alright. After the amount of ptosis, we have to see how much is the levator which is functioning. The function of the levator can be checked by various methods. The most important one is Burke's method. What is this? You hold the frontalis. You block the frontalis. Why you block the frontalis? Because it can lead to false results. You block the frontalis so that frontalis doesn't work. Patient looks down. You block the frontalis and ask the patient to look up. This will give you the amount of ptosis. This is Burke's method. I'll tell you, I'll show you in the examination. This is the most common examination skill which is asked to demonstrate in the exam. And I told you already, the normal function is more than 15 millimeters. Now there is various others, different books have different things. 8 to 15 you can take it as fair LPS action. 4 to 8 millimeter you can take as, 8 to 15 you take it as good LPS action. 4 to 8 fair LPS action, and less than 4 is poor LPS action. So this is a Burke's method. Now they can ask you Burke's method, they can ask you name other method as well. Advanced thing. Other advanced one method is Putterman method. Putterman method. Usually they won't ask to clinically tell, but theoretically they can ask. You ask the patient to look up in up gaze. See, this patient is looking up. The distance from the upper eyelid margin to the 6 o'clock limbus, that will be the LPS action. This is the Putterman's method. Here the patient is doing. What in a child? Child cannot do all these things. How you find in a child is a viva question. So in child you can tell the examiner, sir, we can check by ILF's method in children. How? You just talk to the child, engage the child and just evert his upper eyelid. Evert his upper eyelid and just leave and see whether it is re-everting or not. It's coming to the normal position or not. If it is coming to the normal position, it can tell you that LPS action is at least good. Okay, so everting of the upper eyelid and see whether it's reverting back or not. That is the ILF's method that can be done in children to know the LPS function. Okay, now we come to the important point, the clinical measurements and the clinical examination of a ptosis patient. How you start with the ptosis examination when you're asked in a practical exam. So you start with shaking the hands of the patient. Examiner will ask you, why are you doing this? Not just for introduction, but for checking the grip of the patient to rule out myotonic dystrophy. There is a slow release of grip. Very important point. Then I told you, look at the general inspection. Check for the head posture, whether the patient is having chin elevation or not. You check, you rule out the other causes of pseudotosis, whether the patient is having contralateral lid retraction, ipsilateral hypotropia, ipsilateral small eyes, anophthalmia, phthisis bulbi. Check for the eyebrows. Eyebrow ptosis can be there, brow-ptosis can be there. Then look at the frontal creases. Why frontal creases? Because the patient can, in congenital ptosis, LPS function is poor, the patient tries to elevate the eyebrow, there will be frontal creases. So check for frontal creases as well. Everything you have to tell. Alright, then you check for Hirschberg corneal reflex, whether the patient is having orthophoria or not. If there is a squint, there won't be any orthophoria. Why squint? The patient can have third nerve palsy also. So check the reflex, see the reflex is classically in the center. Hirschberg corneal reflex. Alright, now comes on to measurements. The first measurement in the center is palpebral fissure height. In the center, you check the distance between the upper and the lower eyelid, which I have told you already. This is in primary gaze. The same which you will do in down gaze. Why? Because there is a lid lag in congenital ptosis. Then in primary gaze, you will check. You throw a cornea torchlight on the cornea, there will be reflex in the center. MRD, marginal reflex distance 1 and 2. Distance from the center of the reflex to the MRD 1 to the eyelid margin above and eyelid margin below. MRD 1 and MRD 2. Then in the same primary position, you check the marginal fold distance to the most prominent crease. Fold, that is known as fold in primary. You check from the upper eyelid margin, as I've told you. Then in down gaze, you check the same, the most prominent crease, that will be marginal crease distance. See, patient is down gaze, upper eyelid margin to the most prominent crease, marginal crease distance. That I have told you already. Now they ask you to do the Burke's method of LPS function. So patient looking down, you block the frontalis, you keep a scale, see the margin of the scale, where it is measuring the margin of the upper eyelid, and then now ask the patient to look up and check how much the eyelid is elevated. Now you know the values already, more than 15 is normal. Alright, next you ask the patient to close, tightly close, to look for any lag of thalamus. Why lag of thalamus? Because there is a propensity after the ptosis surgery, there is a propensity that there is lag of thalamus. So check whether the patient is having any lag of thalamus, any scleral show or not. Then Bell's response. What is Bell's response and how you do it? This is a very common question to be asked. See, there are various ways of doing a Bell's response, Bell's phenomena. Check. You ask the patient, you open the eyes manually. There is one method like this. Open wide eyes of the patient like this and ask the patient to close the eyes now. See what is happening. When you do like this, our eyeballs have a propensity to go up and out. This is the normal Bell's phenomena. See, there is no cornea exposure. So this is a normal Bell's phenomena. The eyeball is going up and out. Another method of doing the Bell's response is you ask the patient to so jao, close the eyes, and now you try to elevate the eyelid like this and see whether the cornea is having exposure or not. So two ways I have told you to do a Bell's response. Now important question, what is the normal Bell's response? Eyeball is going up and out. Sometimes advanced question they can ask, what is a inverse Bell phenomena? Inverse Bell phenomena is when the eyeball is going up and in. Inverse is up and in. What is reverse Bell phenomena? This I am taking very advanced points, where the eyeball is going down and out. And one more, perverse Bell's phenomena, eyeball can go in any direction. So normal is up and out, inverse is up and in, reverse is down and out, perverse in any direction. Important point regarding Bell's phenomena. And you can grade the Bell's phenomena as good, fair and poor. More than 2/3 of the cornea has gone up. That is good Bell's phenomena. You can see none of the cornea was seen, means very good phenomenon in this child. 1/3 to 2/3 of the cornea has gone up and is less than 1/3 of the cornea has gone up. That is a poor Bell's phenomena. This is very important in the surgery. After the Ptosis surgery, I'll tell you in complication, there is a lag of thymus. Exposure of the cornea can be there. So if the patient has lag of thymus and poor Bell's phenomena, what can happen? There can be corneal exposure leading to exposure keratitis. Alright. Next you check for the sensations. Same thing. If the cornea is exposed, there will be exposure keratopathy. So you have to check the sensation of the cornea. So come from the temporal, ask the patient to look straight, come from the temporal and just touch the cornea and see whether the eyelid is blinking or not. Why can't you come from the center? Because the patient can be scared and will blink the eye. So come from the temporal and just touch the cornea and see the blinking reflex. Corneal blink reflex. The afferent is the nervous supply of cornea. Fifth nerve is the afferent and blinking, seventh nerve orbicularis is the efferent. Fifth nerve takes the impulse, seventh nerve brings it back. That is corneal blink reflex. And then you check Marcus gun jaw winking phenomena. Jaw winking phenomena. It is a type of complicated ptosis. When the jaw moves, eye winks. So you ask the patient to move the jaw and see whether the eyelid is going up, down, up, down, up, down or not by asking the patient to move his jaw sideways. Chewing gum जैसे खाते हैं वैसे के लिए. You can clench the teeth as well, because I'll tell you, because of pterygoid muscle, abnormal innervation goes to LPS, leading to this phenomena. So this is also important examination, Marcus gun jaw winking phenomena. Then you try to elevate passively the ptotic. For example, right eye is a ptotic eyelid. Try to passively elevate the ptotic eyelid and see the drooping of the other eyelid. This is known as increased innervation test based on Herring's law. So just remember for now, elevate the ptotic eyelid. The other eyelid has a tendency to droop. If there is the other eye has a tendency to droop, it means after the ptosis surgery of this eye, there can be ptosis in the other eye because of Herring's law. This is the increased innervation test and an advanced test. So all these tests are done in ptosis measurements, but don't forget at the end to mention about corneal staining, tear film for the same reason, sensation of the cornea, lack of thymus, and lastly myasthenia gravis, check for myasthenia gravis. So this can be a separate short question. What are the tests for myasthenia gravis? So check like this. Some tests I'll tell you for myasthenia gravis. One is a fatigability test. You ask the patient to look continuously up, approximately 30 seconds. and see whether the eyelid is drooping or not. In myasthenia, more you work the muscle, weaker it gets. So LPS moves up, it becomes weak, it droops down. This is a fatigability test of myasthenia gravis. Second is a Kogan lid twitch test. You hold your two fingers like this and ask the patient to look up, down, up, down, up, down, and look for overshooting of the upper eyelid in myasthenia gravis. That is a Kogan lid twitch test. Then eye peak sign. You ask the patient to close the eyes. Orbicularis close the eyes. Orbicularis is also skeletal muscle. Orbicularis becomes weak. Slightly it will open like the eye is peaking. That is the eye peak sign. And same, the curtain sign is same as increased innervation test. You elevate the ptotic eyelid and see for the drooping of the other eyelid. That is a curtain sign in myasthenia gravis. And we commence, not for the examination in your exam, but for this sweet girl, we can just give her some chocolate for helping us learning Ptosis examination. All these in sequence has to be done in Ptosis examination in the exam. And then you have to tell to the examiner, sir, my diagnosis is whether it's a congenital or acquired. If it's congenital, simple or complicated, mild, moderate, severe degree, with good or poor Bell's phenomena. Like this. For example, just an example, my diagnosis is, sir, simple, moderate amount of ptosis, congenital ptosis, poor LPS action with good Bell's phenomena. This is a diagnosis which you have to tell in the exam after all these examinations. Now what to do? Now, if theoretical exam is there, sir, I would like to do some laboratory management. I would like to do some laboratory studies for ruling out myasthenia. For example, this patient is having right eye ptosis, you can see. Okay, you do tensilon test. 1 milligram of neostigmine intramuscular or IV edrophonium 10 milligrams. These are anticholinesterase. They will increase the acetylcholine and within minutes the ptosis will improve. That is a diagnostic test for tensilon. Similarly, you can do a ice pack test, which I'll tell you when I'll tell you myasthenia in short notes. One more test, sir, I would also like to do phenylephrine test. So phenylephrine will work. It will increase the sympathetic stimulation, and after phenylephrine I will check whether the eyelid is elevating or not. If the eyelid is elevating, means ptosis is improving, it means that you can do molar muscle surgery. So this phenylephrine test will tell you whether your molar muscle is working fine or not, and if you strengthen the molar muscle, the ptosis will improve. Then the management of congenital ptosis. First, congenital ptosis. Congenital ptosis, first important is when to do the surgery. The timing of surgery is important. Usually we take it as 3 to 4 years, because then the measurements, they will ask why 3 to 4 years, because then the measurements will be accurate, patient will cooperative for measurement. So you can wait for 3 to 4 years, except in cases when the patient is having amblyopia, severe ptosis, patient is doing chin elevation, means he is having severe ptosis and the patient vision is getting less, amblyopia patients, then you can do surgery as soon as possible. But generally speaking, 3 to 4 years. What surgery to do depends on the amount of ptosis and the LPS action. So mild ptosis means less than 2 mm LPS, 2 millimeter of ptosis, and usually they have good LPS action. You can do a Fasanella Servat procedure. You evert the eye. Now this surgery only name is important. One to a special point I will tell you, even in your PG exam, when you do a SRship or a fellowship, then you have to detail the steps. But here for mild ptosis, Fasanella Servat procedure, you elevate the evert the eyelid, you take out tarsus, molar muscle and conjunctiva. So it is also known as tarso-molaroectomy, tarso-conjunctival molarectomy. You take out tarso conjunctivomulerectomy to increase the strength. That is done for mild cases. Scientist Fasinella Servat operation. For moderate ptosis, moderate ptosis, you have to do LPS resection. For example, this is a skeletal muscle. You decrease the size. Resection means decreasing the size. You decrease the size of a skeletal muscle, the strength will improve. So decrease the size of the skeletal muscle by cutting the LPS muscle, the strength will improve. That is a levator resection. Can be done from a skin approach, can be done from a conjunctival approach. Conjunctival approach is known as Blaskowitz operation, but you don't have to go in detail with that. So levator resection can be done for moderate ptosis. And for severe ptosis, severe ptosis, you have to replace the LPS. So what is this? This is our nose. This is your eyelid. This is eyebrow. Why I'm doing eyebrow? What elevates your eyebrow? What elevates your eyebrow? There is a muscle over here, frontalis. Frontalis muscle, you elevate, you frown, elevate your eyebrow. So here the LPS muscle is very severe ptosis, very poor LPS action. So what you do is, you join the frontalis to the tarsus. I'm just drawing a line diagram. I'll show you the actual. You join the frontalis to the tarsus. So whenever the patient moves his frontalis, what will happen to the eyelid? It will go up. That is what you want. Here you are replacing the LPS by a sling material. This is known as frontalis sling operation. Frontalis brow suspension or frontalis sling operation. This sling can be of silicone, but the best material for the sling is if you can take out something from a body. So there is a muscle in the lateral part of thighs. You take a part of facial atta, you make a sling of this. That is the best material. You can take it from market as well, silicone material or PTFA. There are various materials. Facial atta, silicone are two important, which you can remember. There are various methods of doing it. This is just a line diagram which I showed. This is actually what is done like this. The sling is over here like this, like a pentagon. Who did it, this pentagon? Fox scientist. So one approach is known as Fox pentagon, an advanced thing. Fox pentagon, all this sling is attached to the frontalis. There is another scientist, you can remember like this. Who did a double triangle technique. There are very more modifications. This double triangle technique is a Crawford technique. So two you can remember the names, Fox pentagon and Crawford modification like this. So this is for severe ptosis, poor LPS action, replacement of the LPS. So mild, moderate, severe ptosis are done like this. Simultaneously, let us, why not, see the instruments which you can be asked in a viva. In ptosis surgery, there are some specific instruments which are used. What are these? I'll tell you the name also. These are to protect the eye globe while doing a eyelid surgery. This is known as a eyelid plate. Jager's name of the scientist. Like when you do a surgery like this, like you do a sling surgery, you're putting some needle like this, and it is put under the eyelid so that it protects the eye globe, so that if you do an incision, it does not hit your eye globe. So Jager's eye plate is this. It is a concave surface. So this surface like this should be going towards the eyeball, because to protect the eyeball is also like a circular thing. Similarly, one more plate is there. Just remember the name, to protect the eye globe. That is a stellard plate for protection of the eye globe during ptosis surgery. Then this is very important. Many times this question will come. This is a retractor. Retractor, pulling. This is a Desmere's eyelid retractor. Like this is the skin approach. You make an incision in the skin for the LPS resection, and the upper part or the lower part you have to retract like this. So see, this is a eyelid Desmere retractor which is retracting the skin over here. Okay, now this. specifically for ptosis. This is a ptosis clamp. Burkase, same scientist Burkase, ptosis clamp. How to use this? LPS rejection, you have to hold the LPS also, no? So you have to hold the LPS so that you can cut it. So ptosis clamp, so that hemostasis is also there. You clamp the LPS muscle so that you can cut it. Ptosis clamp like this. You hold the LPS, you cut it and shorten it in resection. That is a ptosis clamp. Another clamp by the Putterman scientist, Putterman ptosis clamp. Okay, just remember the name and the instrument if it is asked. And then this is the needle, Wright's needle, which is used like this. It is putting into the silicone tube or the facial artery in various incisions, like pentagon incision. It is from one end to the other end. It is put. Wright's ptosis needle can be used in sling surgeries. So these are some instruments which are important. You can remember for your ptosis examination, for a complete examination, like for complete study of the ptosis. Let us see the last complication of ptosis surgery. As I told you, after the ptosis surgery, what important complication they will ask you? There is lag of thalamus, inability to close the eye for some time in the first few post-operative days. So what you do? You do a frost suture like this. From the lower eyelid, you take a suture and stick it over here. You can show you this picture. They ask, what is this suture? It's a frost suture. Why you are doing? So that the patient cornea is not exposed in the first few post-operative days. Frost suture to prevent lag of thalamus in the first few post-operative days. There can be overcorrection or undercorrection, that can be there in any surgery. There can be contour defects. You are doing some incision on the eyelid. There can be up and low contour defects which can lead to ectropion and tropion, can lead to prolapse of the conjunctiva. And as I told you, if there is a ptosis surgery in one eye and the other eye can have a contralateral ptosis also if there is an increased innervation test positive initially. So some complications of ptosis surgery you can mention in your theory exam. Alright, this was the treatment of congenital ptosis. Acquired ptosis. See, acquired ptosis, the treatment depends on what is the cause of ptosis. Neurogenic cause, myogenic cause, mechanical cause. In mechanical, you have to take out the tumor. Neurogenic, just wait for the third nerve palsy. So it depends on the cause. Okay. But during the time, for example, if the patient is having third nerve palsy, for example, if there is a neurogenic patient, third nerve palsy, ptosis because of third nerve palsy, you cannot surgery for that. No? So for the interim period, the patient eyelid is down. So mechanically, you can elevate by giving these specs. These are crutch glasses. See here, these are not normal. These are having, this will elevate your, mechanically elevate the upper eyelid. So during the interim period, when the problem is not being solved, acquired cause, you can give the patient crutch glasses. Even in congenital ptosis, when you are waiting for 3 to 4 years, you can give the child crutch glasses so that the eyelid are elevated. It doesn't look bad. So this can be shown as a picture to be asked at what type of glasses are these crutch glasses for ptosis. That was the complete ptosis examination. But let us now short notes on special topics of some special ptosis. One is complicated ptosis, Marcus gun jaw winking phenomena. If you can see, mostly seen in young male patients. See, the right eye, there is a mild ptosis, and what happens when he moves his jaw? The upper eyelid goes up, down, up, down, up, down. When he moves his jaw, what are the muscles of the jaw? Many muscles, masseter, temporalis. But what is important here is pterygoids. Pterygoids, what is the nervous supply of pterygoids? Fifth nerve. There is an abnormal innervation from the pterygoids to the LPS. So whenever the patient uses pterygoids, the fifth nerve fires the LPS also, and the eyelid goes up, down, up, down, up, down. That is known as a Marcus gun jaw winking phenomena. Is a special type of complicated ptosis because of abnormal fifth nerve innervation from pterygoids to LPS. It can be most common due to external pterygoids, which can be asked by patient to move his jaw sideways, chewing gum, eating chewing gum like that. It can be due to internal also. Internal pterygoids is rare. Clenching the teeth. Clenching teeth, if the eyelid goes up down, that is a rare thing, but can be a cause of Marcus gun phenomena. In all the congenital ptosis phenomena, 5% of congenital ptosis are Marcus gun jaw winking phenomena. And how you treat the patient? क्या करोगे? Always check the basic cause. What is the basic cause? Pterygoids. Pterygoids को ही निकाल दोगे. Take out the pterygoid jaw. Young patient comes to you for Marcus gun. Take out jaw for ptosis treatment. Jaw निकाल दोगे नहीं ना? You cannot take out. Can you take out fifth nerve? No. Can you take out LPS? No. But something has to be done in LPS. You're studying ophthalmology. So LPS cannot be taken out, but it can be disinserted. From where it is inserted maximally? Tarsus. So disinsertion of LPS from the tarsus. What will happen if you disinsert the LPS from tarsus? The eyelid will droop down, total ptosis. So along with this LPS disinsertion, what you have to do? Replace it. And how do you replace it? By frontalis sling operation. For mild cases, unilateral can be done. For severe cases, bilateral has to be done because of Herring's law. So LPS disinsertion plus frontalis sling operation. A short note on Marcus gun jaw winking phenomena, very important. How you check it, I've already told you in the examination. Next, complicated ptosis, congenital ptosis. It's autosomal dominant. That's why you ask for family history. Blepharophimosis, ptosis, epicanthus inversus syndrome. Autosomal dominant. The gene involved is FOXL gene, mostly seen in Rajasthan in India. Blepharo means eyelid, phimosis means small. So there is a decrease in the horizontal aperture, that is known as blepharophimosis. This is ptosis also, of course there is ptosis. And see this fold of skin which is coming from the lower eyelid to above. I also have epicanthus, you have. But we have epicanthus coming from the upper eyelid and coming down. That is epicanthus tarsalis, palpebralis. Here eyelid is, the fold of skin is going from lower eyelid to upper. So epicanthus inversus it is known as. One more feature is there. Increase in the intercanthal distance. That doesn't come in the name, but this is the feature also. Increase in the intercanthal distance is telecanthus. This is the medial canthus of both. Increase in the intercanthal distance is telecanthus. Ectropion can also be the feature of this BPES. Very severe ptosis usually is there. So treatment is severe ptosis, you already know, frontalis sling operation. Short note on BPES syndrome. And lastly, the short note on myasthenia gravis. Very important question. Myasthenia gravis. What happens in myasthenia gravis? There is a problem in the neuromuscular junction. There is a receptors against the acetylcholine receptors. 60% of the patient of myasthenia is a systemic disorder, comes with eye problems. So ocular myasthenia is very important topic as a short note. And 90% of the patient comes with ophthalmic problem in the course of the myasthenia gravis. 60% will present with ocular problem. 90% will have eye problem at some point in myasthenia gravis. So there is decrease in acetylcholine in the neuromuscular junction. So what will happen? It will affect the skeletal muscle. It's a problem of skeletal muscles. So what are the skeletal muscles in the eye? LPS skeletal muscle, orbicularis is skeletal muscle, extraocular muscles are skeletal muscles. So it affects the extraocular muscles, LPS, orbicularis and extraocular muscles. And what is the important point? The more you make the muscle work, the weaker it gets. So what are the important findings over here? If LPS is concerned, the patient will have ptosis. Asymmetrical. It can be asymmetrical ptosis. Bilateral भी हो सकता है, unilateral भी asymmetrical. And the important thing we talk about, fatigable. Ask the patient to look up. The ptosis drops down because it becomes fatigued. Different times of the day. It will be more at the end of the day or morning. The more it works, the weaker it gets. The more at the end of the day. Kogan lid twitch sign I've already explained to you. There is a fluttering of the eyelid. That's also a sign of myasthenia. A curtain sign, I've already told you, increased innervation, a curtain sign is there. And one more sign, this is because of LPS muscle. Because of orbicularis, there is orbicularis weakness, eye peak sign. When you close the orbicularis, it becomes weak. It will slightly open like peaking. That is the eye peak sign. Ask the patient to close, like ask the child to close and look at the any lac of thymus is there, any opening of the eyelid is there or not, peaking. because of weakening of the orbicularis. When you make the orbicularis work, that's the eye peak sign. Eyelid sign is also there, but it's not very important. Eye peak is important because of orbicularis. And third, because of extraocular muscle, what can happen? There is ophthalmoplegia. There is difficulty in the eyeball movements because extraocular muscles are also not working. So that can lead to diplopia. Most common muscle involved is middle rectus, the first muscle to be involved. But any muscle can be involved. So this myasthenia can mimic any cranial nerve palsy. That's an important point. And remember these P's. In myasthenia, there is no P's, no pain, ptosis, pupil, paresthesia, loss of perception. Alright, so that is because of, so we talked about LPS, we talked about orbicularis, and what can be because of extraocular muscles. How you diagnose? Laboratory studies I've already told you, tensilon test. Immediately the ptosis will improve, that's the tensilon test. But please be reminded, they will ask in Viva, if you are giving atrophonium, what will you keep in ready with you? Atropine, because it can cause some heart activity, increase in heart activity. So atropine is kept along with you. First give 2 milligram of atrophonium. If the patient is okay, then you push 8 milligrams. If the patient is having some problem after 2 milligram, give atropine. So atropine has to be kept as a safety in tensilon test. And this is ice pack test. Ice pack, if you put, that will also increase the anticholinesterase activity. Ptosis will improve in myasthenia gravis. So ice pack test, tensilon test. These are two tests which you can do. There are some other tests like electromyogram can be done. Single fiber electromyogram can be done, and antibody testing can be done. But clinically you can do, what is the clinical test you can do? So ice pack test I can do here, standing over here, or I can do a tensilon test as well. These are some investigations which you can do. Treatment is also, I mean, medicine people usually refer to the neuromedicine people for the treatment of myasthenia gravis. Alright, so these are some short notes and complete examination. So what have we learned? We have started from the anatomy of the LPS muscle, then we have seen how to what are the causes of ptosis, classification of ptosis, what is the clinical evaluation of ptosis, in a practical exam how to clinically evaluate ptosis, how to come to a diagnosis, and after diagnosis how to manage the ptosis. In mild, moderate, severe, what are the surgeries, some points regarding instruments we also learned, complication of surgeries, and short notes in some special topics. This is how we are going to do in the topics in the the classes for the residents for MD, MSD, NB. It's a live teaching. This one is a recorded version. So you can see this is a pre-recorded version. It will be given to everyone. And if you want to enroll, this is my code, this is my number, personal number. You can contact me anytime. And I hope we'll see you starting on the 3rd of February. And let's see there how we approach all the things in a manner starting from the first year one, starting with anatomy and then going towards the very advanced levels as well, helpful for theory and practical examinations. All right. Thank you very much for listening. Best of luck. Best wishes, everyone.